Hey, can I run a really challenging patient by you
Sure.
that I saw last week?
Sure.
This is a guy I've been seeing for a number of years. He's really nice. He moved from New York a number of years ago to our clinic in the South to take a new job, and got all the records, and I spoke to his doc from New York, and he's been infected for about 8 years. He's done really pretty well. There's been some lapses in his HIV therapy for periods due to like insurance or some life chaos, but employed, working, taking his medicines. He'd been on boosted protease inhibitors originally when he first started, and now more recently he's on integrase, a newer generation integrase inhibitor. But comes in, I would say, once every few months with concerns about an exposure, been to a party or was contacted by the health department that he was a contact of someone who had syphilis or gonorrhea, or gets texts from sometimes partners that they were diagnosed with an STI. So not infrequently comes in, very well known to our clinic and our nurses, and will get preemptive treatment, and we'll do swabs when appropriate. We have a pretty good system for that. So he's pretty straightforward about that sort of stuff, and has done a great job with it. But I saw him last week, and things were definitely different. Well, 6 months ago, his viral load was undetectable, and his CD4 cell count was in the 600 range. This time he came in, and he was definitely not the same. He was more jittery, much more anxious. Didn't have his, comes in usually with his name badge, from work. Didn't have that on, and clearly something had happened. We started talking, and been fired from his job. He couldn't afford the payments for his apartment, so now he's couch surfing, and admits he's not taking his medicines the way that he should. And when we got more into it, it turned out that things had gotten stressful at work. He'd been starting to use crystal, smoking, then became more forgetful, more absenteeism, and one thing led to another. He got fired. And this has just been this downward spiral for him, and again, really consistently doing well pretty much despite some of these challenges in the past. He does have some depression. He's been on an SSRI for a while, and that's been pretty stable without any need for adjustment. Before this, I was pretty surprised because he drinks socially, but there really wasn't any substance use issues that I had been aware of, but maybe there were in the past that I just didn't pick up upon. That's very possible. And so when he came in, I did get a bunch of testing done because I knew that stuff was going to happen and it wasn't going to be a pretty picture. And I think you could kind of figure out what those showed, and showed that his viral load was no longer suppressed. So that was sort of an issue. His viral load, which again had been long-term undetectable, was now like 4,000, which was really a bummer for me. And I did check chemistries. His AST and ALT were slightly up. And I had thought at the time, as I usually do, to do not only the STD testing, given his recent risk that we usually do, swabs 3 points for gonorrhea and chlamydia, and a syphilis test, but I did do a hepatitis C test as well, an antibody test, and it was positive. And we hadn't documented negatives before. So now I'm kind of stuck. So I got this really nice guy. He's on crystal, not taking his HIV medicines really well, unstable living situation. He's on a high barrier to resistance HIV regimen, so I'm not too worried about resistance, although that's certainly something to think about. And now newly diagnosed hepatitis C infection. Oh, and on top of that, his RPR is now 1 to 512, where before it was after treatment back down to like 1 to 2. So I think this is complicated, and I just don't know where to begin. And I don't know if you guys have had anyone like this before, and what you might do.
Yeah, this is unfortunately, it's not an uncommon situation. Where we have a patient who may have been doing well for quite a long time, and then with the stresses of life and some changes. In some cases, it could be something traumatic, or it could be just a combination of things, and then it leads to poor adherence with antiretroviral treatment, more risky behaviors, and then we have this type of typical presentation. So usually when, a lot of times what happens is for these patients is that what you end up seeing first is that they're missing visits, whereas it may have been somebody who, particularly if they were virally suppressed for a long time, we may be seeing them only twice a year. But then, they miss an appointment, they reschedule, they miss another one, which usually, for us at my practice, it signals, there may be something going on here. Let's see if we can get this patient in and figure out what's going on. Fortunately, he came in.
Right.
In this case, so that's the moment to really start exploring. What's been going on, and then what led to that poor adherence. The question that I would have initially is, did he stop treatment altogether, or is he now taking it just sort of intermittently,
Right.
And then how can we then address that? I would start with that, particularly focusing. Obviously, we want to treat the syphilis, but also we want to address the fact that now there's additional risky behavior, and now, of course, we have hepatitis C, and it's deciding when are we going to treat is an important point for that we need to consider.
Yeah, I think if we're to work our way through his problems, and he's really presenting with a very severe stimulant use disorder,
Right.
dysfunction all over the place, it can be really challenging because there really aren't good medications or much evidence-based treatment beyond behavioral therapy for stimulant use disorders. So we're kind of stuck with, in some ways, this sort of root cause being hugely problematic, and we'll have to consider that when we think about what to do next and how to optimize his adherence to whatever treatment we think about. I know we'll talk about his hepatitis C. Just getting back to his HIV, he's a newly viremic, and we will likely want to check for resistance, although like you said, he has a higher barrier to resistance with his integrase inhibitor regimen, but we'll want to check for integrase resistance assay as well, and just make sure he hasn't newly developed resistance. But getting that viral load back down in this, treatment as prevention in the setting of him having ongoing risk seems like that would be a top priority.
Yeah, no, I think that's really helpful. Yeah, I think maybe making myself a list of the things that are the priorities and doing a good job of trying to put out like the urgent fires, but realizing we have to do some prevention as well for other bad things that can happen to him. Yeah, I think one thing that may help as well is I think this is a hard thing to do alone.
Yeah.
And I think I need to call in some troops in addition to you guys, because I do think that this is going to take some time. And if I could get him into somebody to talk and get some counseling, even if it isn't directly for substance use, although someone who has experience with stimulant use disorders would be really helpful, because I do think I think there's a reason why he started using all of a sudden that I don't understand really well, and I think if someone could take the time and probe that and try to understand more about that, that would be helpful. I have a feeling there's some history there that I didn't pick up before. And we talk a lot about taking a good sexual history. We often don't take a really good substance use history, or find out if there are people who have risk factors for that, and I think he probably did, and I didn't pick up on it. So I think one thing I'll definitely do is talk to one of our social workers who also do a lot of counseling, and even if we do phone counseling with him on a regular basis, that may engage him, and then link him to some community services. That's going to kind of provide us with a basis for moving forward. I agree. I think getting him in for some resistance testing would be helpful. Some of the labs have this reflex where they'll do a genotype resistance test if your viral load is detectable.
Nice.
Our lab doesn't do that, so I'll have to get him in again, but I don't think that there's a huge risk, and I think if he starts back on his medicines, he'll do okay with it. But yeah, I think this is a problem. Now, the hepatitis C is interesting, and it really taught me a lesson, because there's been really good work. There was a study done in the Phoenix cohorts. These are 8 different clinics in the United States, where retrospectively they went back and they looked at when patients at these 8 stellar clinics, our clinic is one of them, had an increase in their transaminases, their ALT and AST. How often was a hepatitis C antibody done? And remarkably, only in a very small minority of cases, even when people had unexplained transaminitis, was hepatitis C testing done. And when I went to medical school, I was taught that hepatitis C, this newly discovered virus, wasn't sexually transmitted. And now we know that it is sexually transmitted.
Yeah.
He doesn't use needles. He acquired hepatitis C sexually. He's a bottom. With crystal meth, we know that people can get involved in more rigorous sex, and there could be more trauma and tearing, more blood exposure. And I think that's exactly what happened to him. And we first heard about this right in the Netherlands, but I don't know if you've seen it, but I definitely have seen some of my MSM, my men who have sex with men, acquire hepatitis C.
Definitely, and he's lucky that, we're all lucky that you sent the Hep C testing. Again, seeing that little flag in transaminitis or just thinking about it ahead of time, because I think there are plenty of people who would see that and maybe attribute it to his HIV or think maybe he's using alcohol on the side or, not really know. So kind of having that on our radar as, you don't need to be injecting crystal meth. You can just be having high risk sex.
Right. And and I think it's a very important point that for men who have sex with men, then there is a true risk of hepatitis C infection, even among HIV uninfected, and this has been seen in PrEP clinics and the group at Kaiser Permanente, where they had in their PrEP clinics, and that they started to see, a lot of acute hepatitis C, which then has led to consideration that in PrEP clinics, maybe we should be testing for hepatitis C, for MSM more frequently. So, for example, in my practice, we test for hepatitis C as frequently as we test for other STIs, for men who have sex with men. So it is important to make the patient aware of the fact that there is this risk of acquiring hepatitis C this way, and also to continue to test for it. So it's kudos for picking that up. That now we have a new hepatitis C infection. What is your thought about the timing of treatment in this case?
I think we're fortunate that we tested him. I've been testing my men pretty much annually, so it's something that we're seeing more and more of. I think this scared him a little bit. He was not happy that he got a call saying we got to talk about. He thought it was just going to be the gonorrhea, chlamydia, the syphilis.
The usual.
Right. The usual that you can get treatment for. He was not easy treatment for. He was not excited that he acquired hepatitis C.
Right.
And he'd heard about hepatitis C, of course. So I think he's a little bit more motivated to do something about it. We talked that it's not a shot of interferon. It's not going to make him sick, because he had heard about this back in New York, and that there is medicine now that he could take for a pretty limited period of time based upon some of the parameters. And he's willing to try to turn over a new chapter. Again, I think we're going to need to support that with some counseling, some social work involvement, getting him into a place where he can deal with some of his issues. Trying to help him as much as we can with some housing stability, I think, is going to be key. His insurance is going to run out soon, so we're going to try to get him onto the public programs that exist to get his medicines. So, again, the HMAP programs and things like that provide not just HIV medicine now, but also antidepressants and other things that I think will be useful for him. So I think it is going to take a village, but I'm keen to try to treat him pretty quickly. I think spoken is that the man does have a bit of a sex addiction, as many of our patients, especially those who are on PrEP or who come in with STDs often. That's another thing that I think we have to label and talk to them. You're addicted to substances, you're addicted to sex. What's going on here, and can we get at that root cause? Because if we skirt around it, we're always going to be at the periphery dealing with it and not dealing with the central issues. And I think we don't do a really good job of that. And it's a balance, because certainly it's companionship, it's affection, it's closeness to another human being. But when does it cross over and be pathological? And this is a conversation that I think he and I have to have, and that I've had with some of my other patients, where it is clear that it's no longer healthy. This is not just dating or just being out there. This is hurting you. And I think this is a big signal for that. And I think that there are some people who really are good at dealing with that, better than your average garden variety counselor. So I think that would be a really important part. So I would start. Good thing is his HIV medicine won't interact.
Right.
He's on TAF and FTC and a newer integrase, and so I don't think that there's going to be any problem based upon what his, and now we have pan-genotypic, so we could even think about, like, do we even need a genotype nowadays? Because we have pan-genotypic drugs. I think he's not going to have a fibrosis score that's high because he's just recently infected, so this is not going to be a cirrhosis case. So I think that the choices for treating him might just have to deal with of the guideline recommended regimens, what can I get the most easiest for the lowest cost.
Yeah, and I think in terms of the time, we've touched on a little bit of this with other cases, but just, he could be one of the 20-30% that spontaneously clear, but are you willing to wait the 6 months while he potentially exposes other people, to see if he clears? And then I think the other challenge with timing is, do you want to see if you can support his adherence to any medication enough that he'll get his HIV viral load undetectable before we embark on what we know is a very expensive treatment? We kind of have like a shot to do it right.
Right. I probably would do that. I probably would really work on his HIV. Like, let's get your HIV viral load down. In the meantime, let's kind of get the paperwork cooking for your hepatitis C therapy.
Right. Yeah, I think that's a great point. While we're counseling about adherence with antiretrovirals, then that's already doing the legwork to get us set up, for success when we treat the hepatitis C. And I think it's the other important point is that, in patients, in HIV co-infected patients who have hepatitis C, we definitely want to treat. We want to move to, if it's possible that they could clear, but it's not something that we want to wait years and years. No. We know that liver disease progresses more rapidly in HIV co-infected patients. So, and as you mentioned, we have such great options for treatment now. I mean, it's a whole new world. Right.
Awesome. This is really helpful. I'm cautiously optimistic, and I'll let you know what happens.
Thank you.
Thank you.
Thanks.
Thank you for joining us. We hope you found this discussion informative. Next, let's summarize the key takeaways as SMART goals that you can implement in your practice. Integrate best practices for improving linkage and retention in care. Improve the rates of HCV testing in at-risk patients. Incorporate guideline recommendations for HIV and HCV treatment.